afternoon. Thank you very much, Mr. Chairman, and my friend, Erectile. Good afternoon. Thank you very much, Mr. Chairman, Dr. Hussein, Dr. Samir Saudi, and thank you again, Dr. Hussein, for giving me this chance to be here with you. Today, my lecture about disturbance of the pituitary, adrenal, gonadal axis in CKD patient and hemodialysis. Really, this title is challenging to me to search for many clinical data that may be applicable to the patient and the background from the clinical background or practical background related to the your patient, either at end stage of the kidney problem or patient related to the hemodialysis. As you see, this is my agenda. First, pituitary abnormalities, then what about adrenal, then jump to the pituitary, gonadal axis. Firstly, hypothalamo-pituitary axis abnormalities in the CKD patient. As you see here, this is the superficially what happens with the endocrine system. We have a hypothalamus and pituitary. This is a superior gland to all endocrine system that start by secretion of the some hormone, what's called releasing hormone from the hypothalamus that make direct stimulation to the pituitary gland. Okay. After that, after stimulating pituitary gland, we have two loops, anterior loop and posterior loop. Anterior loop secreting many hormones that are controlling all body function, starting by what's called adrenocorticotropic hormone that stimulates suprarenal gland to giving cortisol, and after that giving thyroid stimulating hormone to stimulate thyroid gland. After that FSH and LH to stimulate gonads for gonadal and sexual function. Then prolactin, that's important for lactation and so on. Then after that, secreting other hormone like growth hormone is important for growth. As you see, stimulation of the hypothalamus, stimulation of the anterior pituitary, then to the cortex and the gonad. Here an article study the abnormality in the hypothalamus, pituitary, adrenocortical axis patient with the coronary kidney disease. Other article discussing this. Basic endocrinological disorders in chronic renal failure. The endocrinal state of the regular dialysis patient. And lastly, chronic kidney disease and hypothalamic-pituitary axis function, the chicken or the egg. Why we search for all this? Because there is no direct title describing what happened with the renal dysfunction and patient with the end-stage renal problem or with dialysis. But these articles start to describe what's called pathophysiology, and then some tests to prove what happened with these changes, and the other article studies some case report as you see. The first hormone we discussed here, the growth hormone. All of you know the growth hormone is one of the important hormones related to the growth and the maintenance of the life. Growth hormone secreted from the anterior pituitary that don't work directly but work through the IGF1, insulin-like growth factor 1 that coming from the liver. So there is no direct action for growth hormone, but growth hormone work through mediators IGF1. So we have a growth hormone IGF1 action. Growth hormone functionally work on the skeletal and extraskeletal function, also have action related to the metabolism, related to the protein synthesis, related to lipolysis, and action related to the carbohydrate, related to bone growth and skeletal growth. With the young one, needing growth hormone for maturation and go from the child to adolescent period. What happened here with patients with renal failure? Patients with CKD and dialysis found to have altered growth hormone and other hormone related to stimulation of secretion of growth hormone, the growth hormone related hormone from the hypothalamus and the mediator IGF1 system. Uremic patients appear to be insensitive to both hormone, growth hormone and the IGF1, as you see. That might explain that if patients have growth hormone over secretion, there is no acromegaly symptoms, coarse feature, and organomegaly and so on. This is so rare in dialysis patients. In pediatric renal failure and dialysis patients, the disturbance of the growth hormone and the IGF1 may lead to growth retardation. So if you have a patient with the chronic renal failure, this is one of the common etiologies related to the short stature and the delayed puberty. But what happens in adults? Also, an adult needs growth hormone to maintain his life. In adults with insensitive growth hormone and the IGF1 may contribute to the catabolism, to the carbohydrate fat metabolism. So this patient with the renal failure or in dialysis have a weakness, wasting, and fatigability due to absence of the growth hormone action. In dialysis patients, really, there is a resistance to the short-time work of the IGF1 that related to insulin, related to the amino acids, cortisol, and so on. Actually, IGF1 in the blood are normal, but the binding to protein are very high. Because these high IGF binding proteins, this tightly work with the IGF1 and reduce bioavailability of IGF1, and the level of this binding protein appear to increase because they reduce the clearance by the kidney. So, reduce the action. It can be treated, yes, if you have a child with renal failure and go to the period of adolescence. You may know if this have a short stature, you must deal with this problem with the growth hormone therapy. So growth hormone replacement is very important to her to catch growth at time to avoid short stature. Long-term administration of the recombinant growth hormone like norepinephrine or somatotropin that present in the market with the children with the renal failure can achieve linear growth and go to well with the same others with non-kidney disease. Treatment of growth hormone improve also muscle mass and bone density. The dose of growth hormone here differ from the normal one that may be higher and reach 0.3 milligram per kg per week, reach 28 international per kilogram. What about adults? In our practice with the pituitary gland and growth hormone problem, we have a problem with growth hormone abnormality in adults. If hypersecreted, patient have acromegaly, coarse feature. If have a deficient, patient have a fatigue, and the problem to coping with life. So some adults need also growth hormone. But if you give a growth hormone to patient with the chronic kidney disease or hemodialysis, he must get benefit? Yes, he must get benefit related to the increased muscle mass instead of weakness, increased hand grip, increased albumin secretion, and also bone turnover. This is for growth hormone. What about other common hormone ACTH? Adrenal corticotrophic hormone that is secreted from the anterior pituitary gland. That main job of the ACTH to stimulate growth and secretion of the suprarenal gland that help in secretion of the cortisol. So we have a positive feedback and negative feedback. Increasing the secretion of the ACTH leads to secretion of the cortisol. So no secretion of the ACTH, so there is increase in the ACTH secretion with the negative feedback. So what happened? This article describes the pathophysiologic background of what happened with the kidney problem. Adrenal function in a patient with chronic renal failure. Found renal failure dialysis doesn't alter the diurnal variation of the cortisol or the adrenal response to the ACTH, and that happened after many tests to prove this. But in dialysis patient, that patient have a minimal or reduced renal function. Therefore, don't develop salt losing nephropathy that associated with the adrenal insufficiency. In this patient, there is no major manifestation of the Addison crisis. It's called the acute suprarenal failure. But the symptom here is vague, like malaise, signs and symptoms of the hypoglycemia. This is not enough. There's a little data about this, but this article, adrenal insufficiency in the hemodialysis, worked on the case report of the hemodialysis patient, young, coming to the emergency room with the motor car accident and admitted to the hospital, and after 2 days developed fever and treated with antibiotics with empirically and then after culture with no improvement, with more fever, and the case deteriorated after that. And the patient after deterioration, having more tests, started to do tests for the TB, found to be proved to be patient take anti-tuberculosis drug, but minimal improvement, still in coma with more fever. After injection of the steroid therapy, patient go well after 40 days of the fever. And this case report described this article, and this is the question that raised by the European Renal Association and European Dialysis and Transplant Association that this year and last month published, as you see here, 5 case report that explain what happened with the adrenal insufficiency related to the hemodialysis. Here we have a 5 case. First case with the 52 years old female that present only the hyperpigmentation fatigue. After investigation, they found ACTH very high due to loss of the cortisol. This is primary adrenal failure. And after search for the etiology, found this as a TB and treated by the prednisolone 10 milligram per day. This is the first case. Second case, 54-year-old female also, coming to the diagnosed after something with amyloidosis, ACTH not measured, but with treatment of the cortisone, the case improved well, and the first presentation is fever. The last 3 cases describe also the different situation of the presentation and relation to the ACTH level, and this gives the other chance to describe what happened. There is no basic data of the problem related to the adrenal insufficiency and what happened with the renal failure, and this gives the chance to describe this to explain what happened. This is for adrenal. What about other hormones like FSH and LH? You know, follicular stimulating hormone and luteinizing hormone is very important for gonadal and sexual function. So what happened here? This article, Sexual and Gonadal Function, described what happened and found that gonadal dysfunction is a common occurrence in patients with the CKD. It is not rare. Sexual function began with before CKD at the end stage, stage 4 and stage 5, till dialysis, and don't reverse completely with the renal replacement therapy. What about male? Commonly, male come with a decreased libido, erectile dysfunction, premature or delayed ejaculation, or difficulty in achieving orgasm. In females, many problems, also decreased libido, difficulty in achieving orgasm, and lack of vaginal lubrication, pain during intercourse, infertility, and menstrual disturbances. All forms of disturbance of the menstrual cycle are present here. No menstruation at all, amenorrhea. Sometimes oligomenorrhea, polymenorrhea, more bleeding, menorrhagia, and after menopause coming early rather than normal. The gonadal function worsen with progression of the kidney disease till dialysis. 40% of male patients and 55% of the female patients on hemodialysis have a difficulty in achieving orgasm. More than this, 33 patients have no sexual activity at all, and 44% of the female have no sexual activity. Pregnancy, extremely uncommon as one progresses to the advanced stage, pathophysiologically, all of you know that, erectile dysfunction, and this problem related to the psychological and the organic element. What about problem of the FSH, LH, and the prolactin in men? What happened there? Erectile dysfunction in men, seen in the 40 to 80%, this is a large number of patients having erectile dysfunction. We have a psychological factor here, but with effective renal replacement therapy, sometimes improving fitness, improving psychological state, and potency. Erectile dysfunction not related to the etiology of the kidney problem, but the precipitating cause of the kidney problem also related to the diabetes, hypertension, dyslipidemia, some of the underlying pathophysiological changes related to the all element can responsible for this action. Artery, vein, nerve, smooth muscle, hormones, electrolytes. And if you need to deal with the sexual problem and treating sexual dysfunction of the patient with the hemodialysis or patient with the chronic renal failure, you must go with all these elements. What about arterial problem here? You found arterial blood pressure in the pelvis 80 to 10 to 80 to 100 millimercury to maintain blood pressure normal. In patients with renal failure, blood pressure decrease, and once erectile dysfunction occurs before other peripheral vascular diseases happen. And the exact pathophysiology of this, as I said now, with a CKD related, not proved clearly, but related to what diabetes, abnormal lipid profile, accelerated atherosclerosis, and calcification of the vessels, and so on. What about venous system, venous leakage? With a problem in the smooth muscle, precocious aging, and enhanced fibrosis. Benzodiazepine, as you see, concentration very high in CKD patient and dialysis, and 3 to 4 times in transplant recipient in comparison to histamine. So what is this benzodiazepine? This one will be advanced glycation in the product related to the oxidative stress, and this is disruptive to the vessel, to the nerve, and is highly elevated. This is how can you diagnose venous insufficiency in a patient with the CKD or hemodialysis, brief or incomplete erection after intracavernosal injection of the vasodilator, also diastolic blood pressure by duplex ultrasonography, cavernous myography, neurogenic and psychogenic factors. And all of us know we have 3 major elements: psychogenic erection, reflex erection, and nocturnal erection. All these are affected totally in patients with CKD. Also, autonomic neuropathy with parasympathetic system affection is seen in 2/3 of patients more than 65 years of age and 1/3 of the younger patient. And this autonomic neuropathy improved after several months of intensive renal transplantation therapy. What about psychogenic? Here we have Prof. Dr. Rafael Bahari, the head of the Department of Psychiatry, can talk more with us related to the psychogenic problem with the erectile dysfunction in the hemodialysis patient. Drug-inducing erectile dysfunction also that many drugs can cope with this problem. Decreased level of potency can also be due to adverse effects of any drug in the CKD, and this drug interferes with the neurovascular control of benign arteries and smooth muscle and neuroendocrine. These drugs related mostly to the antihypertensive drug like beta blocker, atenolol, propranolol, and so on. Also hormones like estrogen, progesterone, some vasodilators like hydrazine, and sympatholytic drug clonidine, sedatives, psychogenic drug, psychotropic drugs, erectile, cyclic antidepressant, and so on. Digitalis like the digoxin and the ranitidine, all these drugs are playing to make precipitation of the impotence or sexual dysfunction in patients with dialysis. What happened with the axis, FSH and LH, luteinizing hormone and follicular stimulating hormone? In patients with the CKD, increased LH in CKD, due to decreased testosterone release from Leydig cell, no feedback inhibition of luteinizing, so more LH coming, decreased metabolic clearance rate of the luteinizing hormone in the CKD. Normal level of secretion of pulsatile fashion of luteinizing hormone, also follicular stimulating hormone, highly increased in men with CKD with more ratio of LH-FSH, and the presence in your lab high FSH. This gives poor prognostic criteria and signs for spermatogenesis recovery after transplant. What about the axis? Firstly, patients have erectile dysfunction and diminished libido and frequency of the intercourse and improvement of dialysis, but not hormone has not returned back to normal, even with transplant, libido and erectile function remain dysfunctional. Testicular function here affected also for fertility. So semen analysis have a problem, led to the amount, content, and the motility, decreased volume of ejaculate, lower complete azoospermia, low percentage of motility, and what about histologic analysis here? Decreased spermatogenesis in the number, and pathologically we have a problem here in interstitial fibrosis and calcification in seminiferous tubules, epididymis, and atrophy of circulatory cell. Direct sex hormone, we have a problem in both male sex hormone. We have a down regulation of the two form of the testosterone. Total and free testosterone are reduced, and total plasma estrogen very high. This is a problem. Testosterone decreased, but binding capacity are increased, and stimulation test by human gonadotropin give only blunted response in uremic men, so this is a problem also, with possible factor blocking LH receptor in the CKD reversed by transplantation. What about prolactin here? Prolactin, all of you know prolactin F increase. This is coming from sometimes from the hyperplasia or adenoma or microadenoma of the pituitary. This is the case of the prolactinoma or hyperprolactinemia that leads to galactorrhea and gynecomastia in men, and galactorrhea with engorgement of the breast in female. In normal men, severe hyperprolactinemia results in problem with fertility, loss of libido, and low concentration of testosterone level and low LH level. What about in CKD patient? Prolactin level increase, but significance unclear as LH also increase. So we have a here problem between LH and prolactin 2 may distinguish between both prolactin secretion autonomously and resistant to the normal secretory and suppressive measure. We have a lot of major tests, many tests to do this, but we have a problem with the increase of prolactin here. Possible cause of the increase in prolactin here with the hyperprolactinemia in CKD patient, hyperparathyroidism, parathormone infusion in men is a test done, found to have a more secretion of the prolactin level, also zinc deficiency. Gynecomastia with enlargement of the breast. You have a gland in the breast of the men with a CKD, seen in 30% of the hemodialysis men, still pathogenesis after fish unclear, sometimes related to the prolactin level or increased estrogen androgen ratio. Now I said we have a low level of testosterone and a very high level of estrogen in men, and this may reflection of the breast. Patients have soft tissue mass related to the gland in the breast. In men with this problem, we have a different treatment option. Just dialysis for 6 weeks can improve in this condition and increasing testosterone level. Here, the one study showed sexual dysfunction improve after 6 weeks of complete hemodialysis session and make improvement up to 80% after 3 months. Erythropoietin administration also make improvement of anemia. You know, this is our standard treatment of the dialysis led to the anemia and improvement in anemia and in plasma testosterone level also, controlling parathormone level also. Sildenafil and this drug related to the improvement of the function, clomid, sometimes mechanical, testosterone, zinc, and renal transplant can solve this problem. What about women? Women in need for FSH, LH to have a menstrual cycle and to have a stability in her life. We have a 2 phases in the menstruation, follicular phase and luteal phase. First half and second half of the menstrual cycle start by the releasing FSH that work on the ovum and increase. After that estradiol, after that the role of the LH secretion to work on the corpus luteum after ovulation, and after secretion of this corpus luteum secrete estradiol and the progesterone. So we have both half cycle first and half cycle. This is normal. What happened in this female? No progesterone effect on endometrium per biopsy. No increase in the basal temperature that normally and physiologically happen in the female. No pre-ovulatory peak of luteinizing hormone or estradiol concentration. problem of estradiol positive feedback, as exogenous estradiol administration doesn't stimulate LH release. Also, low dose estradiol feedback inhibition intact. Increase in circulating endorphin level in CKD due to reduction in the opioid clearance. Lastly, endorphin inhibit ovulation, possibly by decreasing releasing hormone from the hypothalamus. What about symptoms simply you found in the clinical practice? Female patients on dialysis have a low plasma estrogen level. So, this female have atrophic vaginitis, decreased pubic hair, and some feminine character lost, and also bilirubitis. Menstrual irregularity, as I said previously, amenorrhea is seen in the 50 to 100% in the lower duration at the end recipient disease on measure of dialysis. Increase in the ovarian cyst can occur in uremic patients, and they need to be differentiated from polycystic ovary syndrome and other androgen-producing tumor. What about prolactin in female? In CKD, women have increased prolactin level, hypersecretion like men. Increased prolactin level impair hypothalamic pituitary function with the reflex feedback, contribute to sexual dysfunction also, and galactorrhea. Non-CKD women with prolactin producing tumor present with amenorrhea, galactorrhea. This is usual presentation that are treated by the cabergoline and this drug after suppression of the prolactin, all problem control. But in CKD women treated with the bromocriptine or cabergoline still have amenorrhea and galactorrhea despite normal prolactin. So this gives that sometimes you have a different mechanism related to the hyperproteinemia rather than the different metabolism. Lastly, treatment. Maximize dialysis, correct anemia, oligomenorrhea, hormone replacement like progestin, 5 to 10 days each month to restore menses. Restoring fertility in the end-stage renal disease, women is correct due to complication, but success to pregnancy in renal transplant. After that, patient regain sometimes to normal. Decrease reduction of the studies in this, I researched more, but I found little publication about this. Possible low dose of testosterone, bromocriptine level, estrogen replacement. Estrogen replacement may improve sexual function in women with a low circulating estradiol level, and lastly, the gold standard is the renal replacement therapy. My conclusion simply here, and this is challenging title, to search for, to examine, or to investigate patient have an endocrine problem or endocrine manifestation related to the kidney problem or related to the hemodialysis. Lastly, the kidney play an important role in the hormonal management. Endocrine disorders are one of the most crucial elements of the uremic syndrome, which is underestimated from all of us and has not been fully examined. In renal failure patients, the complex endocrine problem related to the hypothalamus, pituitary, adrenal, and gonadal, also sex hormones and other hormones with the secreted from the adipose tissue. Lastly, there is a great need for more normalized or more randomized controlled trial to evaluate use and treatment approach with the goal of developing a better evidence-based approach for all these problems. Thank you.
Thank you very much, Professor Alain, for your excellent presentation. I want to welcome the coming of Professor Hay. Thank you very much for coming. And I want just to say, do you know the most common symptoms of human beings? The most common symptoms. Any person in renal failure or nephropathy complaint, we have the two most common complaints human being complained are sexual dysfunction and depression. So these are the most common symptoms, irrespective to the presence of dialysis, renal failure. Now the presentation was open for questions. So for dialysis and for consultant treating dialysis patients.
Thank you very, very much. This presentation was really very stimulating and very, very practical. The issue of sexual dysfunction is something that we are actually seeing almost all our patients back at home on dialysis. Yeah, and the management, whatever that we do, seem to be not effective at all. Even when we have adequate dialysis, when we control the anemia itself, like that, no response itself. Now, I want to find out on the measurement of prolactin, at what level would you prescribe bromocriptine? Bromocriptine at home is quite expensive. At what level? Because in most cases, most of our patients with CKD, there's some element of elevated prolactin somehow. Yeah, at what level would you, can it be diagnostic value for you to prescribe bromocriptine?
Actually, there is no practical guideline for this, but you have an international unit and other units, either 20 or 30. If you double this stage, you must start treatment. You have a cheap treatment, you have a bromocriptine and the other drug, you have a cheap drug and rather than this, but you must control the level to avoid all these incoming symptoms. So what is your problem with the replacement of this? I ask you.
Because when you check prolactin itself, different lab will give different figures itself, yeah. So we're not sure whether it's high enough for you to be diagnostic enough for you to prescribe bromocriptine. So I was thinking that it's just some guideline to say, like you have said, maybe double the upper limit of normal itself, like that. Maybe that could be of diagnostic value.
Yes.
Yes.
So if these associated symptoms and this make enemy to the patient, you must start to cope with and return back with prolactin to normal. And according, if this prolactin led to the hyperplasia or led to the problem already in the pituitary gland like microadenoma and so on. So if the disturbed metabolism in the CKD or hemodialysis, you are free to make very low dose, every just one tablet per week and one tablet every 2 weeks and so on, or half tablet. According, this is practical. But if the patient having just microadenoma in the pituitary gland, and you must have control both, just the level of the prolactin and the size of this adenoma to obey reversibility of this size to avoid pressure symptoms. So you must cope with this hyperprolactinemia related to the CKD and hemodialysis, or after MRI related to the problem with the anterior pituitary. You understand what I mean? Okay.
Okay, please.
In French. Nous remercions le conférencier pour la qualité et la richesse en tout cas de sa présentation. Je dirais que en fait mon intervention c'est pas une question en tant que telle, mais je voudrais surtout que vous qui êtes nos maîtres, nos chers maîtres, que vous partagez votre expérience avec nous par rapport au problème, ce problème crucial, parce que le conférencier a touché du doigt le vrai problème auquel nous, en tant que praticiens néphrologues, tous les jours on est confrontés. Les patients dialysés chroniques, de sexe masculin comme féminin. Tous les jours ils se présentent à nous par rapport à ce problème d'impuissance sexuelle. Et il se trouve que dans la pratique, on est vraiment démunis, on n'a pas trop de réponse à cette sollicitation à laquelle on fait face tous les jours. Vous, en tant que nos maîtres, je souhaiterais vraiment partager votre expérience avec nous, parce que très souvent, les malades nous demandent des prescriptions par rapport à ces problèmes. Nous savons très bien qu'il y a les aphrodisiaques, mais nous avons en face des malades qui ont des problèmes cardiovasculaires et nous connaissons les répercussions de l'utilisation de ces aphrodisiaques sur quand même des patients qui posent énormément de problèmes cardiovasculaires. Franchement, nous sommes impuissants, c'est un problème quotidien que nous gérons tant bien que mal tous les jours. Donc mon intervention c'est vraiment à vous, en tant que cher maître, avec votre expérience. Qu'est-ce que vous nous répondez? Quelle réponse donnez-vous à cette préoccupation? Merci.
As I said, common. I think I got the answer of the consultants. You are right. It may be a very important and complex situation because erectile dysfunction in hemodialysis patient is not only hormonal axis disturbance, but it is a body mechanism, endocrinal, vascular, anatomical abnormalities, so it is not an easy task. But we should strive to satisfy the needs of patients. So if the patient comes to you complaining of impotence, and there is, first of all, you will evaluate the patient. If there is no structural abnormalities, it is straightforward to start with sildenafil or any drug of the 5-phosphodiesterase inhibitors, because this will help at least 60% of these patients. And 40% of the patients would be resistant, or there is other local etiology like venous leak or what. So by this way you can transfer this patient to a consultant who is dedicated for erectile dysfunction. In our center we are lucky because we have a sector in urology, which is andrology, and I tried tonight to call Dr. Ahmed Al-Asmi because he is an associate professor of urology, and he is specified, his own specialty, subspecialty is in the erectile dysfunction and andrology. If he is present and not traveling abroad, I'll invite him tomorrow morning to answer your question. Because it is important for the patients and for us. But my teaching point is we shouldn't neglect this symptom, because if you help the patient regarding this problem, this will help him a lot to achieve a better quality of life and improve his psyche. Okay. Professor Samir will want to add something.
I will shift to another question. Professor Ala, this is just, you know that the bromocriptine now can be used for the treatment of diabetes. Of the doses less than the dose double value? Yes. Do you have any patients treated for sexual dysfunction or hyperprolactinemia with bromocriptine and diabetic patient and they have in control of diabetes?
Yes, this is thank you to Prof. Samir for this question. This is an important question, practical. In Egypt, we have no experience about using bromocriptine in diabetes, but it's an observation in our practice. I have 3 patients having hypoglycemia. 2 of them having microadenoma, one a size of the 4 milli and another one a size of the 9 milli. And accidentally discovered the hypoglycemia due to severe headache only. And this patient has diabetes, treated by both oral and diabetic drug. And this patient started to have prolactin level more than 200. I start giving a very high dose of the bromocriptine. After some time, patient start after 2 months having recurrent hypoglycemic attacks. I observed this. I start to make down titration of the oral hypoglycemic. Already I stop sulfonylurea and continue patient on the DPP4 alone. And patient till now is still improving on one drug after 3 uncontrolled state with the up-titrated oral antidiabetic drug. And I found prolactin level down-regulated well till reaching 15 rather than over 200, and the size of the adenoma shrunk in 2 milli than normal. And I asked one of the prof endocrinology in the last 3 months. I attend the Endocrine Society in Boston, 3 months, and having a session with the hyperprolactinemia in practical places. And I asked one of the professors that eminent in the work of the hyperprolactinemia about this problem, and they detected both asked me yes. And asked me if given with the very high dose, 1 tablet daily for 5 days a week can be effective for this and can make both improvement of the glycemic states regarding to the metabolism, also in the level of the prolactin at a level that related to the proper rate of the sexual function and so on, also to the size of the microadenoma, they may be shrunken more and more after 6 months. And this is an experience and no guideline for this.
Thank you very much.
Also, it is very important to review medications again and again and again, because iatrogenic problems are there. So, for example, the most common cause of Cushing is iatrogenic by the use of steroids. And if we use rifampicin, and tomorrow we have a presentation on tuberculosis in dialysis, if we use rifampicin even may enhance the endogenous steroid metabolism and can precipitate a Addisonian crisis in patients. So should be concentrating on the drugs that we will prescribe and may have interaction with this axis. My point is, sometimes the patient is planning for transplantation because we say to him, transplantation is the only hope for the cure of infertility. What's your opinion about that, Dr. Ala? Is transplantation the magic solution for infertility, or still there are some problems after transplantation?
No, and I will Prof. say for this, transplantation can solve many problems related to the sexual function. Transplantation is the magic treatment for all problems related to metabolism and related to all axis problems related to the pituitary, gonadal axis, can restore function, can restore FSH and H level, can elevate testosterone again, and make more improvement of sexual function. I will do totally.
But there is some drugs that we use after transplantation from the immunosuppressive drugs can affect the fertility axis, like mTOR inhibitor class. One of the troublesome complications of this class of drugs is aspermia. So should be careful when you have a male who complains of infertility, because these drugs may be the cause. So we should monitor rapidly sperm count, and if you find sperm count is low, you should stop this class and shift to other classes. And I think the calcium inhibitors are not so benign on this axis. It may affect the lytic cells, etc. So again, yes, transplantation is better than hemodialysis regarding erectile dysfunction and infertility, but there are also situations in transplantation that may oppose the fertility axis. Dr. Samuels. Okay, thank you very much, Dr. Ala, and thank you for your questions. And we'll move to the next speaker.
Now we are moving to the last lecture of our session today. Professor Wafa Bahai is a professor of psychiatry, Mansoura College of Medicine. She is speaking about breaking bad news, which is very important for us. When you will tell your patient for the first time that he has end-stage renal disease and he is in need of dialysis or transplantation, there is a very bad news. So Dr. Wafa today will tell us how to inform our patients about this news.
السلام عليكم. بسم الله. Okay, first of all, I want to thank again my dear colleague, Dr. Hussein Shaisha, Dr. Samir Salhi, for inviting me to be with you today. And many thanks to my dear colleague, Dr. Ghada and Dr. Alaa, which I was so pleasant to hear from them in this day.
I think Dr. Alaa paved the way for the presentation.
Yeah. Yes.